We're diving into a stack of material today that is, frankly, the bedrock of modern medicine. High-yield pharmacology principles.
It really is. I mean, this is the operating manual for how chemicals interact with our bodies.
And the density here is, well, it's immense. But our mission, as always, is not to just list a bunch of facts. We are here to translate this dense medical review material into, surprising actionable insight.
It's such necessary work because when you strip away all the complexity, the real core theme of pharmacology is variability.
Right.
As our source material puts it, for the chemistry that works on one patient may not work for the next because even medicine has its own conditions.
That's a fantastic quote. And it means we need to move beyond just memorizing the drug name.
Exactly. We have to start understanding the why. Why does this drug bind here? Why does the body try to clear it this way? And what are the actual clinical consequences of those rules?
Precisely. And we're focusing on this dynamic two-part dialogue. First, pharmacokinetics.
What the body does to the drug.
How it moves it, breaks it down, gets rid of it. And second, pharmacodynamics.
What the drug does to the body.
The mechanism of action, the maximum effect, the dose you need. I mean, these are the fundamental laws of drug interaction. If you can master these, you master the core of medical intervention.
So let's start small. I mean, really small. At the molecular level, where that first chemical handshake happens. Enzyme kinetics and inhibition.
The moment a drug hits a target enzyme, we're talking about speed limits. And that brings us right to Michaelis-Menten kinetics. We have two critical speed metrics here, Vmax and IMolars.
Vmax pretty simple. It's the maximum velocity of the reaction.
The absolute top speed.
Right. Think of it as the total number of chairs in a factory. It's proportional to the total concentration of the enzyme itself. You can only work as fast as your maximum capacity allows.
And litomolars, the Michaelis constant, is maybe the more interesting concept here. It's defined as the substrate concentration you need for the enzyme to reach 1/2 of that maximum velocity. So half Vmax.
And conceptually, this is huge. A low nodal molar means the enzyme is incredibly efficient and sticky. It loves the substrate.
So it has a high affinity.
A very high affinity. It only takes a tiny amount of substrate to get that enzyme working at half speed. If you plot this out, you get that classic hyperbolic curve where the velocity just levels off as the enzyme gets totally saturated.
But that hyperbolic curve is kind of a mathematical mess, which is why pharmacologists immediately linearize it using the famous Lineweaver-Burke plot. This plot is how we can instantly diagnose a drug's mechanism of action just by looking at how its presence changes the lines on a graph.
This is where understanding the reciprocals is so useful. The y-intercept is 1 over Vmax, and the x-intercept is -1 over Vmax.
So if the line is closer to 0 on the x-axis,
that means the lounge is higher and the affinity is lower. The y-intercept, on the other hand, tells you all about the maximum output capacity.
Okay, let's unpack this with the two crucial inhibitor types because they translate directly into what we see in the clinic. Competitive versus non-competitive.
The competitive inhibitor, while it structurally mimics the natural substrate, it's competing for the exact same active site on the enzyme.
So it's like trying to get into a ticket booth, and the inhibitor is just another person in line.
Perfect analogy. And crucially, you can overcome this challenge by just flooding the system with more of the actual substrate.
And what's the result on our kinetics then?
Since you can overcome it by increasing the dose, the maximal velocity, the Vmax style, remains completely unchanged. But you need way more substrate to get to that half Vmax, so the TPL-Nolar increases, the affinity goes down. Pharmacodynamically, this decreases the drug's potency.
Let's use a clinical example, flumazenil. It competitively antagonizes the TEX-GABA receptor.
Right.
So if a patient is severely sedated with benzodiazepines, and you give them flumazenil, they will suddenly need a massive amount of that sedative to feel anything.
Flumazenil is only reducing the potency, the required dose, but not the eventual ceiling effect, as long as you can just keep shoving more benzodiazepines into the system.
Exactly. Now let's contrast that with the non-competitive inhibitor. This molecule is completely different.
It does not resemble the substrate at all. And it binds to an allosteric site, a totally separate spot on the enzyme.
Wait, hold on. If the non-competitive inhibitor is binding to a totally separate spot, why does that fundamentally change how the enzyme works at the active site? Doesn't the substrate still fit?
That's the key distinction. When that non-competitive inhibitor binds allosterically, it changes the conformation, the actual shape of the entire enzyme complex. The substrate might still be able to bind, but the enzyme just can't perform its catalytic function optimally, if at all.
So this is an inherent functional flaw. which means you can't just overcome it by adding more substrate.
Exactly. You can never, ever achieve the original maximum velocity, so the Vmax decreases.
But because the substrate's ability to bind is still technically the same?
The nother remains unchanged. Pharmacodynamically, this is a decrease in the drug's efficacy. You can never achieve the maximum effect, no matter how high you push the dose. Phenoxybenzamine, which is a non-competitive antagonist on alpha receptors, is a classic, long-acting example of this.
And this brings us right back to the Lineweaver-Burke plot. You can visually identify this mechanism immediately. Reversible competitive inhibitors, since they share the same Vmax, they cross each other on the y-axis. But non-competitive inhibitors, which have a lower Vmax but the same picomolar, they cross on the x-axis.
That visual tool is really the first step in classifying any new compound you discover.
So once this molecular interaction happens, the body still has to handle the drug. Let's zoom out to the macroscopic level. Pharmacokinetics.
Yeah.
How does the body interact with the entire molecule? This has to start with bioavailability, or F.
Right. Bioavailability raises just the fraction of the drug you administer that actually makes it into your systemic circulation, ready to travel to the target organs.
And if you administer a drug intravenously, IV, then F is 100%. By definition, it goes straight into the blood.
But if you take it orally, F is almost always less than 100%.
Why?
Two big reasons: incomplete absorption from the gut and the dreaded first-pass metabolism in the liver.
The liver toll booth.
Exactly. Before that drug gets anywhere else, it hits the liver, the body's primary detox center, which immediately starts breaking it down.
And we calculate F by comparing the area under the curve, or AUC, which represents the total exposure of the body to the drug over time.
You take the AUC after giving it orally and divide it by the AUC after giving it IV, correcting for the dose. That curve is literally the chemical history of the drug in that patient.
So once the drug is in circulation, it has to distribute. This is measured by the volume of distribution. And like you said, this is a theoretical volume.
It is. It describes how much the drug has dispersed away from the plasma and into the body's tissues.
So if a drug has a low V dollars, what does that mean? It means it's stuck in the plasma, right? In the bloodstream.
That's right. Our source categorizes this really well. Low vital drugs are typically large, highly charged, or they're heavily bound to plasma proteins like albumin. They just can't easily cross those lipid cell membranes.
And medium vital drugs.
Those are smaller and hydrophilic. They like water, but not fat. So they'll distribute into the extracellular fluid, the ECF, but they still generally avoid crossing into the cells themselves.
And then you have the high Vita drugs. These are the ones that have, left the building and gone deep into the tissues.
They're small and highly lipophilic, fat-loving. They cross membranes with ease and distribute everywhere, into the fat, the muscle, the brain.
And this is such a crucial clinical insight. Drugs with a high vital dollar are highly effective when they're bound to tissue proteins, but they present a massive problem in an overdose.
A huge problem. If a patient overdoses on a high vital drug like a tricyclic antidepressant, a TCA, you cannot easily dialyze it out.
Why?
Because only a tiny fraction of the drug is actually sitting in the bloodstream at any given time. It's all sequestered deep in the tissues, which makes it incredibly hard to clear out quickly.
Which naturally brings us to clearance, CL, the body's active effort to get rid of the drug.
Clearance is the volume of plasma that's cleared of the drug per unit of time, and it's heavily influenced by the cardiac, hepatic, and renal systems.
The definition is so elegant. C dollars equals the rate of elimination divided by the plasma concentration, CPSE. It's all about matching the rate of removal to the concentration that's actually there.
And clearance is the primary factor that determines the half-life, which is the time needed to eliminate half the drug's concentration.
For the vast majority of drugs, the ones that follow first-order elimination, we calculate the half-life as 0.7 times the volume of distribution divided by the clearance.
And that's the rule for first-order kinetics. The half-life is constant regardless of the drug concentration.
This leads us directly to the concept of steady state. We need to reach a point where the rate of drug going in equals the rate of drug going out.
And for first-order kinetics, this is an exponential process. It requires roughly 3.3 half-lives to reach 90% of the steady-state plasma concentration.
We see this exponential decay so clearly in the table from the source. 50% is eliminated after 1 half-life, 75% after 2, 87.5% after 3, and almost 94% after 4. This fixed schedule of elimination is really the safety net for most drugs.
So metabolism, it's the body's detoxification process. The ultimate goal, as we see in the flowchart, is to convert those fat-soluble, lipophilic, nonpolar drugs into highly water-soluble polar metabolites.
So they can be easily peed out.
Exactly, and this happens in two main stages, mostly in the liver. Phase I reactions are the initial processing step. They often introduce or unmask a polar functional group.
And this is where the cytochrome P450, the CYP450 enzymes, do most of their work.
Right. Reduction, oxidation, hydrolysis. The resulting metabolite is slightly polar, and it might still be active.
And if that's still not polar enough for fast excretion, the body ramps up the effort in phase 2.
Phase 2 is the true detoxification or conjugation phase. Here, the body adds a large, highly polar hydrophilic group-like through glucuronidation, acetylation, or sulfation onto the molecule.
And this makes the drug metabolites highly water-soluble, ensuring they're ready for immediate excretion through urine or bile.
We have to pause here and mention the clinical note about acetylation. The rate of acetylation in phase 2 is genetically determined.
Right, the slow acetylators.
Exactly. Patients who are slow acetylators, for example, when they're taking isoniazid, they metabolize the drug much, much slower than normal. This leads to higher drug concentrations and potentially severe adverse effects like peripheral neuropathy.
It's a perfect example of the genetic variability influencing the kinetics we talked about at the start.
Now let's revisit elimination order, because this dictates the safety profile of every single drug. Most drugs, as we established, follow first-order elimination. The rate of elimination is proportional to the concentration. The half-life is constant.
But then we have the dangerous exception, zero-order elimination, or capacity-limited kinetics. This is where the elimination pathways, often these enzyme systems, they become completely saturated.
Let's go back to our earlier analogy. First order is a modern freeway where the flow speeds up as more cars enter. Zero order is like a two-lane toll booth with no other exits.
The line can be miles long, but the speed doesn't change.
No matter how many cars or drug molecules pile up behind that booth, only a constant amount can be processed per minute. The system is saturated, and it just cannot keep up.
And the rate of elimination is constant regardless of the concentration. The mnemonic for the classic zero-order drugs is PEA.
Phenytoin, ethanol, alcohol, and high-dose aspirin.
This isn't just some interesting math problem. I mean, this is a critical clinical warning.
It's a huge red flag. Since the rate of removal is fixed, the half-life changes. If you double the dose of a zero-order drug, you don't double the clearance rate. You dramatically increase the time it takes to clear that drug.
Meaning the patient tips into severe toxicity much, much faster than with other medications.
So the therapeutic window for these PEA drugs is inherently narrow and really dangerous.
Understanding all these kinetics translates immediately into how we dose things. When we need to bypass the half-life requirement and get to the desired plasma concentration, the CPEPA, right now we use a loading dose.
The loading dose is entirely dependent on the volume of distribution, the V-dole, and it's calculated as Cp tau times V-dole divided by F. We use this when a drug has a really long half-life, like digoxin, and we need the therapeutic effect immediately.
And once we hit that target concentration, we maintain it using the maintenance dose formula,
which is designed to match the input rate to the clearance rate. This formula is Ct2 times the clearance, Cl times tau, the dosing interval, all divided by F.
It's so interesting that the maintenance dose relies on clearance, but the loading dose relies on distribution. Two different goals.
And finally, let's talk about the clever chemical manipulation we use in emergency medicine, ion trapping.
This is how we leverage basic chemistry to flush drugs out of the system during an overdose.
The principle is simple. If a drug is in its ionized or charged form in the renal tubule, it cannot be reabsorbed across that lipid membrane. It gets trapped and is quickly cleared in the urine.
But if it's neutral, non-ionized, it gets reabsorbed.
So if a patient overdoses on a weak acid like phenobarbital, methotrexate, or salicylates, we want to ionize it. We raise the urine pH using sodium bicarbonate. We alkalinize it.
This forces the RCOH-ECA to RCOO plus H plus equilibrium over to the ionized RCOO side, which rapidly accelerates clearance.
Conversely, if the drug is a weak base like TCAs or amphetamines, we want to acidify the urine, usually with ammonium chloride, to increase the ionized RNH3 plus form for trapping.
But there's a critical clinical caveat here related to TCA toxicity.
Right.
While TCAs are weak bases, the initial treatment for a severe TCA overdose is often sodium bicarbonate, which is an alkalinizing agent.
Which seems totally counterintuitive.
It does. But we aren't using it to accelerate elimination in that case. We are using it to treat the specific cardiac toxicity caused by TCAs blocking sodium channels in the heart. The bicarb helps stabilize the cardiac system, which is a completely separate mechanism from the ion trapping we just discussed.
It's those little clinical nuances that turn these theoretical rules into life-saving decisions.
Now we're moving fully into pharmacodynamics, what the drug does to the body. And we have to clearly delineate between efficacy and potency.
Efficacy is the maximal effect a drug can produce. It's the ceiling.
If you look at the dose-response curves, it's the y-axis value, right, where the curve plateaus. A drug with high efficacy is a full agonist, like drug A on our graph. Drug B, which shows a lower plateau, is a partial agonist with lower efficacy.
Potency, AC50 on the other hand, is just about how much drug you need to achieve half of that maximal effect. It's all about the x-axis position. If the curve shifts to the left, the drug is more potent because you need a smaller dose.
This is a key insight. Efficacy is completely independent of potency.
Completely. A drug can be highly potent, so it's effective at a tiny dose, but have low efficacy, meaning it never achieves a high ceiling effect, or vice versa. They're measuring two totally different things: dose required versus maximal output achieved.
Okay, let's apply this to receptor binding types and the antagonists. We use the dose-response curve to categorize these relationships.
The competitive antagonist causes a rightward shift in the dose-response curve.
So you need more agonist, a higher dose, to overcome the competition. Potency decreases, but the Emax dealer
Remains unchanged. You can still hit that ceiling if you just push hard enough.
and the non-competitive antagonists.
That's the structural change we talked about earlier. It inherently limits the function, so it reduces the Emax dollar, the efficacy decreases, and no amount of additional agonist can overcome it. The potency might look unchanged, but the ultimate clinical effect is lost.
And the partial agonists, like buprenorphine, is so fascinating. When you use it alone, it gives you a safe, submaximal effect.
But if you introduce it to a patient who's already on a full agonist, like morphine, it actually acts as a competitive antagonist.
How does that work?
It takes up the receptor space, but only provides a weak effect, which can potentially precipitate acute withdrawal because it's reducing the overall efficacy the patient was experiencing.
Wow. Okay, and we also have the inverse agonist. This one is often overlooked.
It is. Some receptors are constitutively active. They're always generating a signal, even without a ligand. An inverse agonist binds to that receptor and actually shuts down that basal activity, lowering the signal below the normal baseline. Many older antihistamines actually work this way.
Now, the bridge between effectiveness and patient safety. The therapeutic index, TI. This is our safety margin.
The TI is calculated as the ratio of the median toxic dose, the TD50, to the median effective dose, the ED50.
So the higher the number, the safer the drug is.
Exactly. We want the drug to be toxic at a concentration that is much, much higher than the concentration required for a therapeutic effect.
And that safety margin is visualized in the therapeutic window, the range of drug concentrations that treats the disease without causing unacceptable toxicity.
This is why we treat drugs with a narrow therapeutic index as high-stakes warnings.
Like what?
Warfarin, theophylline, digoxin, lithium. Their effective and toxic doses are perilously close. A minor change in clearance, a small drug interaction, or a slight dosing error can rapidly tip the patient into toxicity.
Which means you have to do frequent plasma concentration monitoring. It's not optional.
Not at all.
Okay, so as drugs begin to interact, the complexity just explodes. Before we look at the autonomic nervous system, we need to understand the complex rules of drug interaction.
The most dangerous interactions are synergistic. Synergistic means the combined effect is far greater than the sum of the parts. It's 2 + 2 = more than 4.
And this is why the combination of clopidogrel and aspirin provides a vastly superior antiplatelet effect than either drug could alone. It's a necessity for many cardiac patients.
Right. Then we also have potentiation. This is 2 + 0 = 2. Drug A enhances the therapeutic action of drug B, even though drug A has no therapeutic effect on its own.
The classic example being carbidopa.
Carbidopa, which prevents the peripheral breakdown of levodopa. Carbidopa is useless for Parkinson's on its own, but it greatly increases the amount of levodopa that can actually reach the brain.
Then you've got antagonism, which is 2 + 2 is less than 4, like morphine and naloxone. And then this rapid loss of effect, tachyphylaxis.
This is that acute decrease in response after repeated use. Think of someone who's constantly using an Afrin nasal spray, oxymetazoline. After a few days, the receptors are internalized or just exhausted, and they get that rebound congestion. The drug stops working, and quickly.
Now let's look at the electrical grid that these drugs are targeting. The autonomic nervous system, the ANS.
The parasympathetic system is the rest and digest side. It has long preganglionic fibers and short postganglionic fibers, and it's entirely cholinergic.
Meaning it uses acetylcholine, AHE, at both the ganglia on nicotinic receptors and at the target organ on muscarinic M receptors.
The sympathetic system is the fight-or-flight side. Short preganglionic fibers, long postganglionic fibers. It uses AHE at the ganglia, but typically norepinephrine, NE, at the target organ, acting on alpha and beta adrenergic receptors.
But the exceptions are often the testable points.
They are. Two crucial exceptions for the sympathetic system. First, the adrenal medulla is directly wired to the preganglionic fiber. It uses ADH on null receptors to release epinephrine and NE hormones directly into the blood.
And the second?
The second is that sympathetic innervation to sweat glands is also cholinergic. It uses AHE on muscarinic receptors. That's the cause of that cold, clammy sweat you get when you're nervous.
So this architecture means we have two core types of cholinergic receptors. Nicotinic receptors are fast, ligand-gated ion channels. They cause rapid depolarization by letting sodium in and potassium out.
They're responsible for muscle movement and ganglionic transmission.
And muscarinic receptors are the slow G-protein coupled receptors. They're much more common in smooth muscle, the heart, brain, and glands. They mediate the bulk of the parasympathetic effects.
And finally, in this framework, let's briefly touch on pain. Nociceptive pain is acute and transient. It's the body's alarm system, working through TRPV receptors that cause sodium influx. We treat this with standard anesthetics or opioids that just block the signal transmission.
But neuropathic pain is chronic, often due to underlying conditions like diabetes. It's not about the stimulus anymore. It's about dysfunctional, persistent activation of voltage-gated sodium channels in the damaged nerves.
So we have to target this with drugs that modulate CNS transmission, like gabapentinoids or specialized antidepressants like TCAs or SNRIs.
A fantastic real-world example of this ANS balance is micturition control, the delicate process of filling and emptying the bladder, which is governed by the pons.
When the bladder is filling, the sympathetic system dominates. We want relaxation and contraction. Beta-3/3 receptors relax the detrusor muscle, and alpha-1 receptors contract the internal urethral sphincter.
And when we need to void, the parasympathetic system takes over. 3/3 receptors contract the detrusor, and the sphincter relaxes. And if this system fails, that's when we intervene with drugs.
For a patient with urinary retention, we would prescribe a muscarinic agonist like bethanechol. It hits the 3/3 receptors, forcing the detrusor muscle to contract and empty the bladder.
And for the opposite problem, urgency incontinence or an overactive bladder,
We'd use a muscarinic antagonist like oxybutynin or solifenacin. They block 3/3 to relax the detrusor, preventing those spasms.
and if the issue is a mechanical obstruction from something like benign prostatic hyperplasia, BPH.
We don't touch the parasympathetic system. We block the sympathetic drive to the sphincter. We use an alpha-DOA1 antagonist like tamsulosin, which relaxes the smooth muscle of the bladder neck and prostate.
Moving to the broader class of cholinergic agonists, we have the direct ones. Besides bethanechol, there's pilocarpine, which is used for glaucoma. It causes meiosis to open the outflow tract and to stimulate glands for dry mouth.
And methacholine is used as a challenge test to diagnose asthma. It's a potent bronchoconstrictor.
The indirect agonists, or acetylcholinesterase, ACE inhibitors, are equally critical.
They are. Donepezil and rivastigmine are used to boost ACE in the brain for Alzheimer's disease. Neostigmine and pyridostigmine boost ACE at the neuromuscular junction for myasthenia gravis.
And there's a key chemical distinction here. Neostigmine has a positive charge, which means it poorly crosses the blood-brain barrier, the BBB.
Right, so it keeps its action primarily peripheral. Physostigmine, however, is a tertiary amine, so it crosses the BBB freely and can therefore be used to treat central cholinergic poisoning.
The highest stakes scenario in this class is anticholinesterase poisoning, usually from irreversible organophosphates found in pesticides like parathion. ACE gets permanently inhibited, leading to a catastrophic surge of ACE everywhere.
And this manifests as a systemic cholinergic crisis, which you can easily recall by the mnemonic DMBLS.
Diarrhea.
Urination.
Meiosis, so constricted pupils.
Bronchospasm, bradycardia, a slow heart rate emesis, which is vomiting, lacrimation, sweating, and salivation. It's just parasympathetic overdrive everywhere.
And the treatment requires a two-pronged attack.
It does. First, you have to treat the muscarinic symptoms, the salivation, bronchospasm, bradycardia with atropine, which is a competitive antagonist.
And second.
Second, you have to treat the dangerous nicotinic effects, specifically the neuromuscular blockade that causes respiratory failure. For that, you need preladoxim, which actually regenerates the ACE enzyme.
So atropine saves the life, but preladoxim prevents respiratory death.
Exactly. And speaking of atropine, let's detail the systemic effects of these muscarinic antagonists or anticholinergics.
Atropine blocks M receptors everywhere, which results in an increased heart rate, decreased secretions, decreased GI motility, and the ophthalmologic effects of mydriasis, or pupil dilation, and cycloplegia, which is a loss of accommodation.
The adverse effects are a famous mnemonic that just perfectly summarizes the breadth of muscarinic control. Hot as a hair.
Because decreased sweating leads to hyperthermia. Dry as a bone.
Dry mouth, dry eyes, red as a beet.
Flushed skin. Blind as a bat.
Cycloplegia and mydriasis, mad as a hatter.
Seen as confusion and delirium. And finally, full as a flask.
Urinary retention.
It's incredible that a single small molecule can orchestrate that many diverse physical symptoms at the same time just by blocking the parasympathetic side of the equation.
It's a testament to the sheer control exerted by the muscarinic system.
So now we flip to the sympathetic system, the gas pedal. We rely on adrenergic receptors for cardiovascular and respiratory control.
And we need to nail down the function of the alpha and beta receptors. Alpha-DAL1 mediates vasoconstriction in almost all vascular smooth muscle.
So it causes increased peripheral resistance and increased blood pressure. It also causes mydriasis and smooth muscle contraction in the bladder sphincter.
Alpha-2 is the internal brake. It's presynaptic and inhibitory. When it's activated, it reduces the further release of norepinephrine, providing negative feedback.
Beta-Gen1 is primarily in the heart and the kidney. It causes an increased heart rate, which is chronotropy, increased contractility, which is inotropy, and crucially, increased renin release from the kidney.
And that drives the body's long-term blood pressure control.
And beta-10 is distributed widely in smooth muscle. It causes bronchodilation in the lungs, vasodilation in skeletal muscle arteries, and glycogenolysis in the liver and muscle. Basically, beta-2 activation always leads to relaxation output.
Right, and beta-23 helps relax the bladder and stimulate fat breakdown.
All of these receptors are G-protein coupled. A quick cellular reminder, alpha-DALR and M1M33 are linked to GNAS.
Beta-1, beta-2, beta-3, D-Gen1, and 10-enoliner are all linked to GNLers, which stimulates adenylate cyclase and increases CAM-MP, which is generally stimulatory.
And alpha-2 D2-DUs and M2-DALRs are linked to DLRs, which inhibits adenylate cyclase and decreases CAM-P, which is generally inhibitory.
And this mechanism explains why stimulating beta-1 increases heart contractility through G-DALR and CAM-P, while stimulating alpha-2 reduces any release through G-DALRs.
The noradrenergic synapse itself is a massive drug target. NE is released, it acts on receptors, and then it's mostly recycled by the NE transporter back into the nerve ending.
And drugs exploit this transport system. Amphetamines don't just block reuptake. They're actually transported into the neuron via NET, and then they force the non-vesicular release of NE and dopamine.
Conversely, cocaine and SNRIs, they just block the reuptake pump, the NET.
Right, which leads to an increased synaptic concentration of catecholamines. This is why a topical solution of cocaine is still used in ophthalmology. If pupil doesn't dilate after you give cocaine, it confirms a lesion in the sympathetic pathway.
Because the nerve ending isn't releasing any NE for the cocaine to trap and amplify.
Exactly. Okay, let's analyze the direct sympathomimetics table by their receptor affinities and their corresponding clinical effects.
Dobutamine is primarily beta-1 over. It increases cardiac contractility without causing excessive peripheral resistance.
So it's the go-to drug for acute decompensated heart failure or cardiogenic shock, where you just need to boost the pump.
Epinephrine is the ultimate mixed agonist. Beta is greater than alpha. At low doses, the powerful beta-2 vasodilation dominates, often causing a decrease in peripheral resistance.
But at high doses, the alpha-DALR1 vasoconstriction kicks in, leading to a massive BP increase. It's the perfect universal agent for anaphylaxis because it stabilizes the airway with beta-2 and the blood pressure with alpha-DALR1.
Norepinephrine is alpha-1 beta-1. It is one of the most potent vasoconstrictors available. It causes a dramatic increase in both systolic and diastolic blood pressure.
However, because that intense alpha-dollar vasoconstriction causes such high pressure, the body's baroreceptors immediately trigger a powerful reflex bradycardia via the vagus nerve to slow the heart rate down.
Even though the NE is stimulating beta-dolin in the heart at the same time.
Right, and this makes NE used mainly for severe septic shock, where systemic vascular resistance is dangerously low.
The graphical comparison in the source is really the key to mastering this section.
Absolutely. Look at isoproterenol. It's pure beta-1 equals beta-2-2. The beta-2 activity causes massive vasodilation, so peripheral resistance just plummets.
And while beta-9-1 increases heart rate and cardiac output, the severe drop in resistance means the mean arterial pressure, the MAP, it drops or stays low.
The heart rate, however, spikes, driven by both the beta-1 stimulation and reflex tachycardia.
Now look at norepinephrine. The strong alpha effect causes severe vasoconstriction, BP spikes, and that reflex response dramatically drops the heart rate. The cardiac output is often unchanged or even decreased because of the intense afterload.
And epinephrine sits right between them. It increases systolic pressure via beta-HARDA1 and high-dose alpha, but often decreases diastolic pressure via beta-2-2 vasodilation. The net result is an increased pulse pressure, increased cardiac output, and increased heart rate.
And this brings us to the truly fascinating pharmacologic magic trick: epinephrine reversal. This is what happens when you block one side of the system.
If you administer an alpha blocker first, and then you give epinephrine, you have removed the vasoconstrictive alpha-1 brake. What's left is the unmasked beta-22 activity, which is pure vasodilation.
So instead of increasing the pressure, the patient's blood pressure drops. The pressure response has been reversed.
It's a critical diagnostic test to confirm the presence of mixed alpha and beta activity.
Now, contrast that with phenylephrine, which is a pure alpha-1 agonist. If you block the alpha-DOL receptors first, the pressure effect is suppressed, but it is not reversed.
And why is that? Because there's no hidden beta-2 vasodilatory activity to reveal. It's an alpha-mediated event, period.
Okay, moving to the brakes of the sympathetic system, we start with the central actors. Alpha-2 agonists like clonidine and tizanidine.
By stimulating that inhibitory alpha-2 receptor in the brainstem, they reduce central sympathetic outflow.
Clonidine is used for hypertension, ADHD, and managing opioid withdrawal symptoms. Tizanidine is effective for muscle spasticity, but they carry a major risk.
CNS depression, bradycardia, and a severe high-stakes warning of rebound hypertension if the medication is stopped suddenly. The body's own sympathetic system just comes roaring back online, completely unchecked.
Okay, next up, the alpha blockers. We separate them into non-selective and selective.
The non-selective agents are used in high catecholamine states. Phenoxybenzamine is irreversible and long-lasting. Phentolamine is reversible. They are both used to stabilize patients with pheochromocytoma,
Which are tumors that secrete massive amounts of catecholamines.
before surgery, right? And a key practical insight here, phentolamine is also the antidote for norepinephrine extravasation.
What's that?
If an IV drip of NE leaks out of the vein, it causes such intense localized alpha-1 vasoconstriction that the surrounding tissue dies. Phentolamine, when you inject it locally, rapidly reverses that vasoconstriction and saves the tissue.
And then we have the alpha-1 selective blockers, easily identified by the elzosynthix, prazosin, terazosin, tamsulosin.
They specifically target the alpha-1 receptor, relaxing peripheral and prostate smooth muscle.
So they treat BPH urinary symptoms. Tamsulosin is particularly used because it's selective for the urinary tract with fewer systemic side effects, and they also treat hypertension. The big side effect to watch for is first-dose orthostatic hypotension.
That's the sudden inability to compensate when you stand up due to peripheral vasodilation. It can lead to dizziness or falls.
Okay, on to the beta blockers. These are fundamental cardiovascular tools used for an immense variety of conditions.
Their primary action in angina is reducing myocardial oxygen demand by decreasing the heart rate and contractility. In chronic heart failure, they prevent the chronic, deleterious remodeling effects of constant sympathetic overstimulation.
They treat hypertension by decreasing cardiac output and decreasing renin release from the beta-IL-1 receptors in the kidney. They're essential post-myocardial infarction to reduce subsequent mortality. And propranolol is often used for migraine prophylaxis and essential tremor.
Let's decode the selectivity table, as this determines when we choose one beta blocker over another.
The beta-1 selective, or cardioselective agents, are often remembered as going from A to M in the alphabet: atenolol, bisoprolol, metoprolol.
These are generally safer for patients who also have underlying lung disease, as they minimize the risk of beta-2-mediated bronchoconstriction.
And the non-selective agents, which hit both beta-twig and beta-2-ors, they go from N to Z. Nelol, propranolol, timolol.
Timolol is crucial for glaucoma because beta-2 blockade reduces aqueous humor production. Propranolol, being non-selective and lipophilic, readily enters the CNS, making it effective for migraine prevention.
Then we have the combined alpha and beta antagonists, carvedilol and labetalol.
These offer the benefit of vasodilation from the alpha blockade, along with the cardiac protection from the beta blockade, which makes them really powerful agents for managing hypertension and chronic heart failure.
And nebivolol, a newer agent with a modified suffix, is unique because it also increases nitric oxide syntase.
Right, giving it an extra direct vasodilatory effect beyond its beta blockade.
The adverse effects are a serious concern, though. They include fatigue, erectile dysfunction, and CNS effects like sleep alteration or depression.
And most importantly for diabetic patients, beta blockers mask the symptoms of hypoglycemia, like tachycardia and tremor, which are mediated by the sympathetic nervous system. This can lead to a delayed recognition of dangerously low blood sugar.
Our final specialty group in this section are the phosphodiesterase PDE inhibitors. These drugs leverage the second messenger system by blocking the enzyme that breaks down CMP and/or cGMP.
So they extend their duration and increase their effect.
The non-selective PDE inhibitor, theophylline, increases CAMP and is used for COPD and asthma, but it's an older agent with a dangerously narrow therapeutic index.
It causes significant cardiovascular toxicity like tachycardia and neurotoxicity like seizures.
The most well-known class is the PDE5 inhibitors, ending in alisfil. Sildenafil, tadalafil, vardenafil.
These block the breakdown of cyclic GMP, or cGMP. Increased cGMP leads to prolonged smooth muscle relaxation and potent vasodilation.
And this is the mechanism used to treat erectile dysfunction and pulmonary hypertension, where sustained vasodilation is key.
The adverse effects here are a crucial safety warning. These drugs absolutely must not be co-administered with nitrates, like nitroglycerin, for angina.
Why not?
Both drugs increase cGMP, and the synergistic effect causes a massive, precipitous drop in blood pressure that can be fatal.
Sildenafil also has that unique adverse effect of inhibiting PDE6, which is found in the retina.
That's right. It causes visual disturbances, most notably cyanopsia or blue-tinged vision, a highly specific side effect.
And finally, we mentioned PDE3 inhibitors, such as milrinone. These are powerful intravenous drugs used in acute decompensated heart failure. By increasing KMP in the heart muscle, they increase contractility, acting as a potent inotrope.
Okay, so moving from therapeutic use to toxicity, we can start with environmental dangers, specifically seafood toxins, which demonstrate rapid and violent effects on the ANS.
Histamine, or scombroid poisoning, comes from spoiled dark meat fish. Bacterial breakdown converts histidine to histamine, and the symptoms are, well, they're indistinguishable from an allergic reaction.
Facial flushing, wheezing, itching. And the treatment is simple. Antihistamines.
Tetrodotoxin from the pufferfish is infamous. Its mechanism is a potent block of voltage-gated sodium channels. It prevents nerves from depolarizing,
leading to rapid paralysis, paresthesias, and a loss of reflexes.
Now, ciguatoxin from reef fish is the inverse. It opens sodium channels, causing persistent depolarization. And the bizarre and classic symptom is the reversal of hot and cold sensations.
Allodynia, right, along with profound bradycardia and hypotension.
Now, let's consider pharmacology in the context of age. Why do we need to dramatically reduce doses in older patients?
Because the changes in pharmacokinetics are systemic.
Distribution changes dramatically. Older patients have decreased total body water and increased total body fat.
So hydrophilic drugs suddenly have a smaller volume to distribute into, leading to higher plasma concentrations. Lipophilic drugs, however, have a larger V dollars due to more fat tissue, so they accumulate for longer.
And metabolism slows down. Decreased hepatic mass and blood flow means the liver is less efficient, specifically affecting phase 1 CYP450 reactions.
Phase 2 conjugation reactions tend to be less affected by age, which is interesting.
And excretion is the most significant factor. Decreased renal mass and blood flow lead to a substantial, often clinically silent, decrease in the glomerular filtration rate, the GFR.
So if the drug is primarily cleared by the kidneys, the dose must be reduced, or toxicity is inevitable.
Antidotes are the specific keys needed to unlock a toxin's hold. We have to know this list.
For acetaminophen overdose, we use N-acetylcysteine to rebuild the body's protective glutathione reserves, preventing irreversible liver damage.
Opioids are reversed with naloxone, a competitive receptor antagonist. Organophosphates require that combination therapy of atropine for the muscarinic effects and pralidoxime to regenerate HE and reverse the nicotinic effects.
Benzodiazepine overdose is reversed with flumazenil, a competitive TEX-GABA receptor antagonist. Carbon monoxide poisoning is treated with high-flow oxygen, ideally hyperbaric oxygen, to displace the CO from hemoglobin.
And for heavy metal poisoning, we use chelation. Iron is treated with deferoxamine, and lead poisoning is managed with dimercaprol and EDTA. These targeted treatments are really the ultimate expression of pharmacodynamics.
Okay, this next section is a minefield of potential interactions, and we'll use the source material to highlight the specific mechanisms that make these reactions so dangerous.
In the cardiovascular system, torsades de pointe is a fatal rhythm caused by a huge array of drugs that prolong the QT interval. Class IA and 3 antiarrhythmics, many antibiotics, antifungals, and TCAs. We use the mnemonic memorize your ABCDEFs to recall the general classes that cause this risk.
Cutaneous flushing, that sudden redness and heat, is a sign of histamine release. This is classic for vancomycin, which causes red man syndrome, niacin, which is often pretreated with aspirin, and calcium channel blockers.
In the endocrine system, the sudden discontinuation of glucocorticoids is a major cause of adrenocortical insufficiency, as the exogenous hormone has suppressed the body's natural production.
Hyperglycemia is a significant side effect of both tacrolimus, an immunosuppressant, and protease inhibitors. Patients on these therapies have to be monitored for new-onset diabetes.
And the syndrome of inappropriate ADH, or SIADH, which causes dangerous hyponatremia, is caused by drugs like carbamazepine and cyclophosphamide. The body just inappropriately retains water and dilutes the blood.
In the gastrointestinal tract, focal hepatic necrosis is the signature toxicity of acetaminophen due to its toxic metabolites overwhelming glutathione and also the deadly amatoxins found in death cap mushrooms.
And pseudomembranous colitis is the serious gut superinfection caused by C. difficile overgrowth. It's triggered by broad-spectrum antibiotics, especially ampicillin, cephalosporins, and quinolones, which wipe out the competing healthy gut flora.
The hematologic system is highly sensitive. Aplastic anemia, where the bone marrow just stops producing blood cells, is a devastating side effect of chloramphenicol, NSAIDs, and benzene exposure.
Direct Coombs-positive hemolytic anemia is caused by the body generating antibodies against drug-coated red blood cells, a classic side effect of penicillin and cephalosporins.
And thrombotic complications are primarily estrogen-mediated, seen with oral contraceptives and hormone replacement therapy. Estrogen increases blood viscosity and promotes platelet aggregation, raising the risk of deep vein thrombosis and pulmonary embolism.
Under musculoskeletal and skin, drug-induced lupus presents just like systemic lupus erythematosus and is associated with hydralazine and procainamide.
Malignant hyperthermia is a crucial high-acuity pharmacogenetic reaction to inhaled anesthetics like isoflurane and the paralyzing drug succinylcholine.
It involves mutation in the ryanodine receptor, leading to massive uncontrolled calcium release, severe muscle rigidity, and fever, and the specific antidote is dantrolene.
Stevens-Johnson syndrome, or SJS, a severe mucocutaneous blistering reaction, is associated with anti-epileptic drugs, especially lamotrigine, as well as sulfonamides and penicillin.
In the neurologic category, we see motor complications. Parkinson-like syndrome is a result of dopamine receptor blockade, a common side effect of antipsychotics and the antiemetic metoclopramide.
Tardive dyskinesia is a severe movement disorder, also caused by chronic antipsychotic use and metoclopramide, which often involves irreversible, repetitive, involuntary movements.
And peripheral neuropathy is a painful complication of platinum agents used in chemotherapy, like cisplatin, and the anti-seizure drug phenytoin.
Finally, in the renal system, interstitial nephritis, which is inflammation of the kidney tubules, is caused by diuretics like furosemide, NSAIDs, and penicillins.
And under multi-organ effects, the high-profile disulfiram-like reaction occurs when drugs like metronidazole or griselfulvin are mixed with alcohol. These drugs inhibit aldehyde dehydrogenase,
leading to a massive buildup of toxic acetaldehyde, which causes severe nausea, flushing, and hypotension.
Okay, focusing on the eye. Pupil size is a direct visual cue of ANS activity. Mydriasis, or dilation, is sympathetic, caused by alpha-DOLA1 stimulation of the radial muscle.
Which is why anticholinergics like atropine and sympathomimetics cause dilation.
And meiosis, or constriction, is parasympathetic, caused by M383 stimulation of the sphincter muscle. This is seen with opioids, organophosphates, and cholinergic agonists like pilocarpine.
Now back to the kitchen sink of kinetics. Cytochrome P450, CYP450 interactions. These are the enzymes that dictate drug clearance for half the drugs on the market. Inducers speed them up, inhibitors slow them down.
CYP450 inducers increase the rate of drug metabolism. So if you give a patient an inducer, they clear their co-administered drugs faster.
Which often leads to therapeutic failure because the drug concentration never reaches a therapeutic level.
The key inducers we have to recall are St. John's wort, phenytoin, phenobarbital, rifampin, and chronic alcohol use. The long mnemonic helps here. St. John's funny fin mom never refuses greasy carbs and chronic alcohol.
CYP450 inhibitors do the opposite. They slow down drug metabolism. If you give a patient an inhibitor, their co-administered drugs accumulate, potentially leading to rapid toxicity. This is a high-stakes scenario, especially for drugs with a narrow TI.
Key inhibitors here include sodium valproate, isoniazid, cimetidine, fluconazole, and the widely consumed grapefruit juice. The mnemonic, "sick faces come when I am really drinking grapefruit juice," helps us recall the full list of agents that suppress this enzymatic activity.
Grapefruit juice and statins are a classic pairing. If a patient on a statin, which is metabolized by CYP450, drinks grapefruit juice, an inhibitor, the statin concentration dramatically increases, raising the risk of severe muscle breakdown, rhabdomyolysis.
These are the interactions that are routinely causing adverse events in the real world.
So we'll finish our deep dive by mastering the secret language of pharmaceutical nomenclature. If you know the suffix, you know the drug's mechanism of action. Let's decode the system line by line as per our source material.
Starting with antimicrobials. If a drug ends in aspir, it targets hepatitis C by inhibiting NS5A, like lidipasvir.
If it ends in lisophilin, it inhibits transpeptidase for bacterial cell wall synthesis. Ampicillin.
Condols means it's an ergosterol synthesis inhibitor, like ketoconazole.
Cyclane is always a protein synthesis inhibitor, like tetracycline. And if you see Navir, it's a protease inhibitor used to treat HIV, like ritonavir.
For antineoplastics, cuplatin signifies a platinum compound, acting as an alkylating agent. Cisplatin.
Rubicin is an anthracycline, a powerful chemotherapy agent like doxorubicin, and utaxyl signifies a taxane, which affects microtubule stability like paclitaxel.
Moving to CNS agents, anabarbital denotes a barbiturate, like phenobarbital.
Amylocaine is a local anesthetic, blocking sodium channels like lidocaine, and the anxiety agents are split. Agezobam and anzolum identify the classic benzodiazepines like diazepam and alprazolam.
Autonomic, cardiovascular, and metabolic agents are probably the most common. Azole is a beta blocker, propranolol.
Anipril is an ACE inhibitor, captopril. Acerten is an angiotensin II receptor blocker, losartan.
Ardipine identifies a dihydropyridine calcium channel blocker, primarily affecting vessels, amlodipide. Metastatin is the HMG-CoA reductase inhibitor, the cornerstone of cholesterol management, like atorvastatin.
And the newer diabetes agents also have predictable suffixes. Liflumsin is an SGLT2 inhibitor, which increases glucose excretion in the urine. Daclitazone is a PPAR gamma activator.
Finally, the new frontier of biologic agents. These are often massive proteins and antibodies, and their names actually encode their origin, all monoclonal antibodies and in lifmab.
And the prefix tells you the history. Nipsumab means it's chimeric part mouse, part human, like rituximab.
Glugamab means humanized, so mostly human, like bevacizumab.
And umab means it's fully human, like denosumab. The closer the drug is to human, the less likely the patient is to develop an adverse immune reaction to it.
And for the small molecule inhibitors that act intracellularly, the suffix inib is key.
Coxibib means it's a COX2 inhibitor, like celecoxib, and tinib means it's a tyrosine kinase inhibitor, like imatinib.
These naming conventions turn what looks like this chaotic list of obscure terms into a completely logical, structured system that's based entirely on the mechanism of action.
We have truly moved through the entire spectrum of pharmacological science today. We started with the...
And this leads us to our final provocative thought for you to consider. We meticulously detailed the extensive lists of CYP450 inducers and inhibitors, everything from common supplements like St. John's wort to everyday consumables like grapefruit juice.
So, given the sheer number of drug interactions that can subtly or dramatically change a drug's clearance rate, how many seemingly minor and unreported interactions are contributing to unexplained adverse effects or therapeutic failures in the population right now? Simply because the patient had a glass of juice or took a supplement we didn't ask about.
The complexity is vast, and the details are everything. A truly challenging question. Thank you for joining us for this extensive deep dive into the high-yield principles of drug action. We hope this has given you the confidence to approach this critical material not as a set of facts, but as a map of dynamic rules.